Welcome to today's Antibiotic Stewardship Echo Clinic, where we will be talking about TB screening and management. I want to start off with introductions. So we have Dr. Charlie Krasner, Susan McElhaney, and Mike Stander here. And I'll pull up something else that we want to share with you all. Really great announcement for Boulder City Hospital getting national recognition for their antibiotic stewardship program. Wow. Part of being connected with us through Project Echo here. They got this great award. Yeah, I see the group there, Nevada Rural Hospital Partners, celebrating. So, yeah, great work, Boulder City. Great to have you guys on here. Hope to keep working well with you. So, Charlie, you want to take it away?
Yes, please. So, I take care of the TB clinic here in Wausau, and we have just introduced the new QuantiFERON-TB Gold Plus test, and it's really a major milestone in the evaluation of TB exposure because, and I wanted to go over this, because it really, for the first time, may give us a clue to how active the disease is. Are we dealing with just latent infection or active disease infection? So this is the first time we have this opportunity using a blood test to give us an idea how active an infection is. So I wanted to go through this. Just obviously, we've all used the TB skin test. The skin test, a lot of problems. First of all, you got to hope the person you're testing comes back. Secondly, you can have 5 people read a PPD and everybody gets a different reading on it. And probably the biggest drawback to the skin test is that we don't have any internal controls, which means we don't know the health of the person's immune system. Is it really a negative PPD, or do they have, inability to respond to it? So a lot of those things have been replaced by the QuantiFERON. So most guidelines are we don't do skin testing anymore. Because QuantiFERON, it's one-time visit. It actually gives us, instead of a subjective reading, it gives us an objective test result. It can go right into the EMR. And probably most importantly, it gives us an idea, internal controls, whether or not this patient's immune system is attacked. It can really give us a positive or negative test result. So it's called gamma interferon. These are gamma interferon release tests. What is gamma interferon? Basically, you think of it, you're exposing the immune system to antigens, which are found in TB, so parts of TB. And then the memory cells, parts of the lymphocytes, we call them, I think it's like the general of the immune system. They, if the general recognizes that this person has been exposed to TB, they then send out the alarm. The alarm is called gamma interferon. The gamma interferon's sort of an inflammatory messenger that says, bring in the troops. And so all these, the gamma interferon brings in all these inflammatory things, TNF, et cetera, that help fight the infection. And so what we're seeing when we do a skin test, it's that iteration that we feel is actually the gamma interferon causing inflammation. And so that's what we're reading with the skin test. But when we do the reading with the gamma interferon test, the QuantiFERON test, we're actually measuring that gamma interferon. Okay, so the memory, the CD4 cell, also called the helper cell, sort of the general of the system. It says, I recognize TB, and it sends out the alarm, and the alarm is by gamma interferon, which brings the troops in. And so that's basically, we're measuring what is previously was the induration of the skin test. And so there's been a whole, I mean, why are we doing skin testing or gamma interferon testing? We really want to know whether or not somebody's been exposed to TB. But up till now, the PPD and the QuantiFERON test did not tell us any idea about how active disease is. It says, yes, you've been exposed, or no, you've been exposed. And then we've had to take that test result and then look at the patient. Does this patient just have sleeping TB, latent TB, or do they have active disease? Do they have a negative X-ray? Or do they have infiltrates, coughing? And so it's really been a clinical diagnosis. We used the test up till then just to say, yes, he's been exposed. And now the clinician has to say, is this active or is this not active? And so for the first time, we're adding a new test to the QuantiFERON, which gives us an idea, which supports the the possibility that we're dealing with active or new infection. And so there's been evolution of this QuantiFERON test, and the one we're most familiar with it was the QuantiFERON-TB Gold, which over the last 10 years has been our standard. It's been easy to do, it's done in a test tube, and it's given us the answer whether or not, yes, you've been exposed or not, you've been exposed. But now with this new test, we have new testing going on, which actually allows us to see whether or not this disease is not only present, but whether it's active. And so this is what makes it the plus of the QuantiFERON Gold test. So we're going to go over that. Okay, so up till now, all we were using, we're looking at were the helper cells, the CD4 cells. This was the general, basically saying yes or no, but wasn't telling us the active disease. So the CD4, the helper cells, which is tube 1 in this test, does not tell us anything about disease activity. If it recognizes TB exposure, it releases gamma interferon and says, yes, you've been exposed. But what the new test does, we look at the CD4 called the helper cells, but now we look at actually sort of the soldiers of the immune system. These are the killer cells. These are the ones that get activated when there's active disease. They go in there and they try to kill off the TB. And so we have the general, yes or no, been exposed, and then we have the killer cells getting activated in the presence of new infection or active disease. And so they also, these killer cells also release gamma interferon. So not only do you have gamma interferon being released by the helper cells, but now you have these killer cells, the soldiers, also secreting gamma interferon in the presence of infection. What happens is that throughout your life, the helper cells will say, yes, you've been exposed, and it can stay positive forever. But when you're actually dealing with active infection, the killer cells get active. Once they've done their job, they shut off. And so if you find that your CD8 cells, the killer cells, are producing it, this would suggest that there's something actively going on. And so this is what's been looked at. So if you look at on the right, you see the 4 tubes. We'll talk about the nil and the mitogen. But tube 1, TB1, is basically the helper cells. This is the old tube from the previous QuantiFERON Gold, not the Plus. This gives us the answer, exposed or not. TB2, which is the new tube in the QuantiFERON-TB Gold Plus, has the helper cells in that tube, but now they're throwing the killer cells on top of that. So if we found that the TB1 is positive, the TB2 is positive, but there's really no difference between the gamma interferon releases, that would suggest you probably have inactive disease, just a latent infection. But if you look at TB1 and TB2, if there's a big difference with the TB2, which has not only the helper cells, but also the killer cells, if you see an increase in amount of gamma interferon between TB1 and TB2, the greater it is, the more suggestive that you have activated killer cells and possibly an active and new infection. So on the left side, what they've done here is taken TB2, which is the helper and the killer cells, and they subtracted the TB1, which is the baseline cells. So on the left, it says you see low risk. So these are patients where the TB2, which is the helper and the killer cell minus TB1, is basically the same, suggesting you're probably dealing with inactive disease because TB2 and TB1, there really is not much difference in the release of gamma interferon because the killer cells are not activated and not producing anything. If you look at patients who are considered mixed risk, well, these are patients, maybe roommates or housemates, been exposed to active disease. Now we're starting to see that TB2 minus TB1, you're starting to see a difference where tube 2 is significantly greater than tube 1. And when you look all the way over where you have active TB, where not only you have the TB1 producing gamma interferon, but now you have the TB2 killer cells, you can see there's a much greater difference, suggesting that you're probably dealing with activated killer cells and you're dealing with active disease. And so this gives us, one more look at if you see a difference between these 2 tubes, the TB2, the greater it is in TB1, suggests maybe you're dealing with a new infection or even a great difference in active disease. Does that make sense? Because we'll keep on going and give you some examples of that. So we'll just skip this for a moment. So we have 4 tubes we're dealing with. We have the TB1 helper cells, TB2 helper plus killer cells. Okay, the first tube is called the nil tube. The nil tube is basically, we want to see, we take the CD4 cells, we take all the cells, the immune system, we want to see, are they at baseline producing any gamma interferon? The immune system isn't stimulated, we'd expect to find very little baseline gamma interferon production. So that should be pretty low. close to 0. So that's your baseline, because when you start exposing it, you want to know what your baseline is to see if there's a significant difference. So that's the nil. Baseline gamma interferon should be pretty low. On the right side is called the mitogen. A mitogen is a protein which activates all your immune systems, not just T cells that recognize TB, but recognize all the different antigens and things we're exposed to. So you turn on the entire immune system, okay? Everything gets stimulated. And you can say, wow, does this, now that we stimulate the immune system, are we showing gamma interferon through the roof? Is the immune system able to actually recognize gamma interferon? Or is the immune system so sick that even when exposed to mitogen, when you turn on the T cells, it doesn't do anything? Okay, so nil control, what's your baseline gamma interferon? Mitogen control, let's see if these T cells actually work. Let's stimulate them. Let's see how much gamma interferon. And oftentimes we see, the nil control could be 0 or very low. The mitogen could be 10, 20, 30, 40, an amazingly high response. So this saying, yep, if this immune system record is exposed to TB, we know it's healthy and it should respond, okay? There's two possible reasons that you may not get a mitogen response. If you remember the old test, you had to rush the gamma interferon test to the lab, because if it sat out, the T cells could deteriorate. So if it sat out, wasn't prepared properly, these T cells will just deteriorate in the cell, and that's one possibility. Or the other possibility is that they're still immunocompromised, maybe very advanced AIDS, maybe cancer patients, maybe on hydrosteroids, that they have no ability to respond. So for the first time, with these two tests, we have a negative control. We know whether or not this immune system result we can trust. Okay, so we have TB, we have nil control, baseline, TB1. This is basically the old test, the old QuantiFERON test. The CD4 cell, it's the general saying yes or no, we've been exposed. TB2 is the general plus the soldiers. We have yes or no, plus we have natural killers cells going out there fighting the infection. The greater difference between 1 and 2 suggests more active disease. And then we have the mitogen, which says, yes, we can believe these results because the immune system's healthy. All right, so on the old QuantiFERON-TB Gold, it's like a month old, QuantiFERON-TB Gold, a positive test, since they only tested the TB nil, the TB, the CD4 cells, it was 0.35 greater than the nil. So if you had a nil value of 0.5, TB minus nil would have to be 0.85 or greater, because the 0.85 minus the nil has to be greater than 0.35 is called positive, okay? On the new test, they're increasing the sensitivity of this test. So TB, the old TB1 minus nil, which is like the old QuantiFERON, still has to be greater than 0.35. But TB2 also has to be greater than 0.35. So both of those tests, either one of those two tests must be, are considered positive. The old one test was positive, but on the new one, only one of those two tests have to be positive. So by increasing the sensitivity of this test, even if only one of those two tests or tubes are positive, one could be negative, one could be positive, test is called positive. And that doesn't seem like much of an issue, but it's really an issue which we'll talk about when we're screening low-risk patients. All right, so basically, when you see a test result, what do you expect in a healthy person with no risk of false negative? We want to see a nil value closer to 0 because the immune system's not activated. You want a mitogen result greater than 10, showing the immune system's healthy. And then you want to look at TB1 and TB2. You want to make sure that TB2 and TB1 are about the same, or TB2 is greater, and see if anything doesn't fit with what you know. What to expect? TB1, TB2 value should be close in value, or the TB2, the helper and killer value should be greater than TB1. And you say that makes sense, but I've seen mistakes in interpretation. All right, so this is giving an example. This was presented, and it was an interesting case. Exactly, because you might be involved in a TB exposure after an active case. So this is from a South American country. There was an educated rheumatologist. There wasn't much of a public health system to help her, so she called up to the San Francisco TB clinic for advice. She had 3+ smear-positive cavitary TB, and you can see on the right side on her lung there, a big cavity. So this is a very contagious lady. And she's been coughing for 2 months, so very likely that she's going to expose people around her to tuberculosis. So she takes the contact investigation upon herself with advice from San Francisco, and her strain is susceptible to all medicines. She has 2 daughters, age 1 and 3, a babysitter and a husband in her home, and her sister visits. So she does a QuantiFERON-Plus test on everybody in the household. So if you look at the test on the right, the husband's positive, so he's been exposed, which means at least one of the 2, TB1 or TB2 was greater than 0.35. The babysitter's positive, the sister's positive. Her sister's positive. But now she has 2 daughters, and the 2 daughters are both negative. She gets x-rays on all of them, but she's obviously concerned about her daughters, even though they're negative. Everybody's put on INH for prophylaxis. And so this is, let's look at her, the daughter H3. This is her baseline lab. On the left side, it's in Spanish, but the QuantiFERON-TB Gold Plus. This is the daughter, this is her first test. So we look at, what's the first tube we look at? The nil tube, okay? 0.06, very low. That tells us the immune system's not been activated. Then the next tube we look at is the mitogen test. The last tube on the bottom, it's greater than 10. Okay, so we know that this child, she's 3 years old, she's got a healthy immune system. So let's now expose that immune system to TB. So we look at TB1, 0.02. That means it's less than 0.35, it's negative, right? So the 0.02 is actually 0.08 minus 0.06, because it's the TB1 minus the nil, the baseline. Okay, and the TB2, also completely negative. Okay, so this child at baseline is negative. So then she comes back 8 weeks later, like when you do like a TB test or anything else on this child. And now the nil is 0.05, the mitogen greater than 10, so she's got a good immune system. And now her TB1 is 2 and her TB2 is 2. So she has converted in those 2 months, and was very appropriate that she was started on treatment. A very good response. The other child remained negative, and unlikely that this child has been exposed to tuberculosis. We probably could have her INH discontinued. So that was the 1-year-old child. Again, the child was nil, 0.3, superior than 10 on both tests. We know these were good tests that we could trust and was properly done. The child has a good immune system. So this is where I think that a little bit of an issue with this medicine. This test may be a little bit too sensitive. This was a nurse, 42-year-old Montana-born nurse, who gets annual healthcare worker screening. She's had no travel or TB exposure, no meds, no medical problems, normal exam, has had negative skin tests in the past. So she gets the QuantiFERON 2015, 2016, she gets the old standard QuantiFERON Gold test. 0.04 is 2-1, or they're both negative. In 2017, she now has the plus, the TB1 test, which is similar to the old test, is 0.45. So that means her TB2 test is 0.01. She has one of the 2 tubes are now positive, so she's read as positive. But what seems strange about this is, one, the TB2 should be probably almost the same as, if not greater than the TB1. So, you know, this is a little bit strange. You may wonder about how accurate this test is, but this and her. But again, 1 tube is enough to consider it positive. So they repeat the test, and now it comes back as you'd expect. It's basically 0 for TB1 and TB2. All right, so Stanford looked at this, and this was a test. They've done annual QuantiFERONs on their test, and they found when they did the QuantiFERON Gold versus QuantiFERON Gold Plus, they found a slightly increased number of patients who were positive on the QuantiFERON Gold Plus versus previously. And they identified a number of these patients that were now had positive tests, and they felt that they were very low risk. And 11 of them were considered positive because only 1 of the 2 tubes were positive, which is the definition. So then they said, let's take a conservative definition of this test. They repeated it, and now these were both negative, suggesting that, you know, in a patient's pretest probability is very low for TB, where you have 1 of those 2 tubes as positive, it's most likely just a lab variation. They suggest that you just go ahead and repeat it. So maybe we shouldn't even be testing patients who have low risk. Why are we testing patients where they probably shouldn't even be tested? So I want to go finish up here. Just have you take some quick look at some of these QuantiFERON tests. So the QuantiFERON-TB Gold Plus, which tells you it's got the TB2, which is the helper and the killer cells. So what do we look at first? We look at the nil, right? It's nice and low. We then look at the mitogen value, greater than 10, very healthy. So then we look at TB1, which is the, as I said, it's the helper cell. It's the general saying, yes or no, I've been exposed to TB. Is that positive 0.59? Right? It's greater than 0.35, so that tube is positive. Now we look at TB2. It's 1.09, so this is the helper and the killer cells being tested. And so that's almost twice as high as the TB1 antigen value, okay? So it tells us, one, that the helper cells are responding, but two, you may have activation of the CD8 cells producing the killer cells, the soldiers. The soldiers have become activated. They're out of their bunkers and they're fighting. So this may be somebody you'd be concerned about, either a new infection or active disease or recently infected, okay? So this is where the new TB Gold Plus adds to the old test, because in the old test, we would have just had the TB1 antigen value to say, yes, he's infected. But here, it's giving an idea that maybe this patient's acting for a recent infection. You may want to be more aggressive about this situation. Okay, so this was at the VA. Dr. Asinelli is our, she does all the employee stuff. And so all of a sudden we have this new test here and we're getting positive tests and everybody got panicky. And these were a bunch of providers in the emergency room. We had not had any known TB exposure. So let's look at their results. The TB nil, 0.08. And on the bottom you see mitogen, greater than 10, so healthy response. So then they list the results a little bit differently. TB antigen is 0.2, but we need to get the 2-1, we have to take the TB antigen 1 minus the nil. So it's 0.2, which is result, minus the nil, 0.08. So the TB antigen 1 minus nil is 0.12. The second tube, TB antigen 2, is 0.49 minus 0.08. So now you get 0.41. So again, one tube is negative, the second tube is positive. And then it's called positive. We had three patients, three providers who had this, and we then repeated it, and again, it came back negative. Okay, so if this is technically called positive, but you know, if there's low risk situation, then we didn't think these providers have been exposed to TB, and when only one is positive, you may want to go ahead and repeat the test. And again, all three of these were negative. And we were talking, Sue and I were just talking earlier, we had a bunch of new medical students who had never had exposure. And I think 5 of them had positive tests, and we repeated them, they were all negative. Okay, so it's no free lunch with this new test. Again, this is another person, this was a physician renowned. Nil value 0.53, mitogen greater than 10, TB1 0.38. So he's 0.03 above the test, positive. His TB2 minus nil is negative. Again, barely positive one, technically a positive test, but we repeated and it was negative. And last one, this was the one we got at the Hope's Clinic, was read as positive. Let's look at this. Let's see, this is why it helps to look at the test. QuantiFERON nil value, 0.05, good nil. What do you look at next? The mitogen, 0.05. That doesn't make sense, right? And the TB2 antigen is 8.29. So what have they done here? TB1 was 0.04. Everything else is nil. We called them up and they had switched entered the numbers wrong. Okay, so this was everybody got excited about a positive test, but this was put into the computer wrong. All right, so it has to fit. So it's really helpful. Look at the nil. Look at the mitogen. Does it make sense? And this obviously didn't make sense at all. So I'm going to stop now, and Sue's going to have a patience.
Yeah, should we transition to Dr. Thomas?
Yes.
Okay.
You're welcome.
So yeah, I'm Susan McElhaney. I am the Nevada State Tuberculosis Controller and Program Manager. And I was introduced to Dr. Thomas. I'm glad he reached out to our program because they, reported the QuantiFERON result and we kind of went from there and figured out our game plan. So I wanted to actually take this time to give you guys some resources that are out there. So that's kind of what my little segment is going to be. So, okay, so my
Go ahead.
my favorite thing is the CDC Analogy for tuberculosis. So I was exposed to that. I've been in TB about 2 years. So about 2 years ago, I went to a training course and they showed this slide. And why I like it is because TB disease, what everyone fears, the active infectious state, it's just the tip. So what we really are looking at now is that bigger part below the surface, okay, the latent infection. And the more providers that feel comfortable with diagnosing it and treating it, we're going to eliminate this incidence of TB in our country and our world. That's the goal. So I've also made a little analogy of my own that you've got your big iceberg. Well, that QuantiFERON result, it really is, it's just the tip. Like, what do you do with that? Do you panic? Do you do more tests? Well, yes, you definitely need additional tests. You need tests to figure out, does this person have an active state of TB? Do they have an infected, sleeping, latent state? Which would be additional tests.
Like still sitting there in the same spot.
Go ahead.
It'd be x-rays, clinical exam, signs and symptoms. And then once you've got that information, you probably need to dig a little deeper and find out infectiousness and isolation. Is that needed? And finally, there's even treatment. Treatment comes with its own burden of the medications you're giving them and interactions. So there's a lot to be dealt with, and I don't want you to feel like this huge underneath the surface is supposed to bog you down, because there are resources to help you. So first of all, I would like you to go to the CDC as much as you'd like. Their website, CDC TB, basically provides a tremendous amount of resources, maybe almost too many. But I'm going to focus you guys a little bit on their special latent infection, because again, we're trying to recruit providers to really help in the certain populations that should be screened. So they now have a little toolkit, latent tuberculosis, latent TB, yep, right there. If you click on that, they provide all sorts of great things, but at the bottom of this particular page, there's these fact sheets for providers. So it should answer many of your questions. And then there's also patients, because a lot of people have asked, well, what do I tell my patient? What do they do? What can they encounter? So they've tried to make this very friendly. The CDC also provides a lot of their information for patients in many different languages. So explore their website as much as you'd like. The other thing, another tool for you here to kind of go with your QuantiFERON results and your TSTs. I mean, TSTs are still used a lot. There's an interpreter tool called it's called the TST in 3D, okay? So it can do both TST results or IGRA results. And it's an online tool that you will ultimately get estimates. Once you punch in, there's a lot of patient demographic information needed. And like, they need to know their age, were they BCG, vaccinated, what country did they come from. You have to provide some information. But from that, you come up with estimates like, is this a true result? How likely is this a positive? Or what is their annual risk, given all that information of it actually developing into active TB disease? And then it even looks at lifetime risk. So that's a neat little tool to use. Like I said, you do need patient information. The other tool that I really like, this is my little go-to, is this Clinician's Pocket Card. It's something that Rutgers Global Tuberculosis Institute put out, and it's actually pretty microscopic. So if you actually go to their website and just expand on the card with your computer, you might see it better. Just really quickly, what it has different places on this card. It has who to test and who to treat. IGRAs, you'll see that when you get a positive result, they're saying treat all these people, contacts, immunocompromised. There's so many reasons. With the TST, you really need to consider the actual result, rather what size. But IGRA is always pretty much a positive. If it's truly positive, it's recommending treating. Then there's even like when to use an IGRA and when to use a TST. There's scenarios for you on that, and maybe you should retest. If you don't like that result, it doesn't seem to fit with your scenario, they suggest retest. There's recommendations on drug regimens and treating for LTBI. which again, that CDC, LTBI little toolkit, they're a wonderful place to apply this information and their information. And then they have managing. They kind of give you a really brief lowdown on what you should be considering, like when to run baseline tests and what patients might encounter. So the big push right now, besides in populations that are at high risk for developing the tuberculosis active infection, is to get these people treated, and short course treatment is really the big push. It's a 3-month, once-a-week treatment. And sometimes people get a little nervous about, what do I do? What does this look like? So I feel like the National Tuberculosis Controllers Association has put on a really great resource. It's a 2-sided reference sheet. You have to go to their site to download it, but it pretty much walks you through, you know, why should you do this and why shouldn't you? Which patients shouldn't you do it? Literally, like what these pills look like, alerts about it, monitoring, again, what kind of monitoring? So it's a tremendous resource. And I think one thing I haven't mentioned is all of these, like these slides are available to you. At the end of the slideshow, I have all the resources listed again with their links. And I even have a 2-sided resource page based on this slideshow. So we can get that to you if you request copies of the slide set or the PDF with these resources. So other resources, oh, this is a fabulous one. If you decide you've looked at all this paperwork and you still just don't know, you really want to talk to somebody in person. The Curry Center, which is in San Francisco and Oakland, they do have training materials. Like if you go to their website, you can find all sorts of neat things. They've got a great radiographic one, pediatrics. But what I think their real value to some of us, especially you out in the rural communities, is they actually have a consultation service. You can talk to somebody, a warm body, a warm line, where they have, you can phone call them, you can email them, you can ask them questions about treating for the latent tuberculosis infection, or if you are concerned about disease, what are my next steps? I mean, what should I do? Do I, infection control, I mean, that kind of ties in, what do I do next? How do I, maybe you're revamping your hospital's program on infection control. They can offer assistance. So they're a fabulous resource. And finally, there's my program. So I have a website. I have contact information. That's how you can call me. If we're going to kind of look into this website a little bit. On our website, what I think is a great, on the right side are the resources, the publications. In our publications, we provide quite a few resources. Some of you are familiar with our Fast Facts, which would give you all the Nevada statistics on incidence of TB. In each Fast Facts, we'll have the past 5 years with them. So some of you call about, hey, how many cases of TB in, you know, Washoe County? It's there for you. Thank you, Troy. Okay. The other thing on that publications list is we have a Nevada TB manual, which has, you know, plenty of information on from diagnosing disease, active disease, to diagnosing latent tuberculosis, and then treatment. And the 2 chapters I think that might be relevant for you is the introduction, because it gives a lot of context, like who can I call? We really want you to call your most local health department and work with their TB department. The other one would be our chapter 10 has a surveillance and reporting. It kind of goes over that same situation of, well, I think I have a case, what should I do next? So please, yeah, that's okay, we can skip that, yeah. You know, please reach out to my program. I can always connect you with a local health department if I need to. I can connect you with Dr. Krasner. We can talk about Curry. Okay, and then I guess I get the next slide. So what I want to say is I really thank you for your time. I want to thank the CDC. They've made a lot of this possible, most of it. But please don't feel like that, okay? That there are plenty of resources for you, real people resources too. And together, we can all work together and we're going to end TB. And those are resources all available to you.
Do you guys have any, before you leave, do you have any QuantiFERON test results you want to tell us about, that you have questions about?
yeah, anything you'd like to share, please feel free to take yourself off mute with the icon in the lower left corner, or use the chat function.
Yes, the other thing is if you have a QuantiFERON and you have a question, just take a picture of it and send it to me.
Mhm.
I get pictures of smelly legs.
And if you don't have a direct link to Dr. Krasner,
Yeah.
send it through our TB program. Like, call me and I can get it to him. Yeah, the actual lab slip is tremendously helpful, especially with this new plus, right? There's those two different cell responses, so to compare them is very helpful.
All right, any questions or anything before we wrap up?
That's great. Okay.
Thank you so
Thank
much,
you all.
everyone. So we'll be back next month. What will the date on that one be? So it'll be the 21st. We'll be back here. So hope to see you then. Thank you.